So first of all, thank you for coming to today. Today I'm going to talk through basically mastering medicines management. It is quite a tricky topic to get right, but a lot of practices do get it right just throughout from doing it for years. But I'm just here to make sure that everyone is following all the updates and are aware of the updates. So a little bit about me, first of all, because some of you may not know me. I'm Danny. I work at Agilio as a compliance analyst. I've got over 13 years of experience in dentistry. I'm also a dental therapist. I still work in practice, and I'm also a dental nurse as well. So I know the challenges that everybody faces in different roles. I also know the perks of the jobs. So I'm quite keen to try and help everybody. I've got a vast experience in NHS, private practices, referral centres, secondary care hospitals. So I know from all different angles of the different challenges that we face. I've also been a professional educator, business manager, infection control lead. And something that I'm really passionate about is trying to make life as easy as possible in dentistry. And that's with compliance, clinical work. I'll always say to patients, we want to make life as easy as possible. So the plan for today is to run through medicines. So first of all, we'll do a little brainstorm just to try and get everybody's brains into gear with where medicines are and what to think about. Then we'll have a look at the law briefly and what changes have recently been made, which is the exemptions, which you've probably heard floating around. And then we'll also start having a look at just the main processes of medicines in dentistry. So the administration, prescribing, supply. And we'll also touch base on what healthcare regulators then do look for as well. So in terms of medicines, it's a huge topic, and like other aspects of dentistry, it's essential to get right, and this is to reduce the risk to staff and service users. So we'll just highlight the key areas to consider, and you'll be able to start seeing how they all interlink. So first of all, we've got various legislation, and this determines what must be done in relation to medicines, but we'll touch on this in more detail on the next slide. We've also got the MHRA, so Medicines and Healthcare Products Regulatory Agency. They're responsible to ensure that the medicines are basically safe and effective. They're also responsible for the yellow card reporting site, which you may have come across before. And this is where adverse reactions to medicines are reported to. Then we've got the BNF, so British National Formulary, and this details the medicines that can be prescribed. So this will be on a private basis in a dental practice. We've also got the DPF, which is the Dental Practitioners Formulary, which is what can be used for NHS prescribing. It's a little bit more restricted with the medicines that can be prescribed on the NHS. Then we've also got guidance such as CG-DENT, NICE guidelines, just to help us basically comply with the law. Healthcare regulators, again, are there to support us and also make sure that we're meeting our requirements and meeting legislation. And then, as mentioned, there are differences with NHS and private dentistry, where NHS is a little bit more restricted. So looking at medicines, there's different rules for different types of medicines. So it's essential to basically understand what they are. So we've got general sales list, so GSL medicines. These are what you'd be able to purchase from places like supermarkets. So paracetamol, 0.05% fluoride mouthwashes, your normal toothpastes. So anything that you just normally go to a shop to purchase. These are things that can also be sold at practices. Then you've got your pharmacy medicines. So P medicines such as Diflam, Corsidil gel. That's where you'd have to go to visit the pharmacist normally and then purchase it over the counter from the pharmacist. So you normally have to just discuss what the problem is and they would provide it if it is appropriate. So again, this is something that practices can have available, but they are a little bit more restricted than GSL. And then the most restricted one is your POMs, so prescription-only medicines. So these are where you need a physical prescription from a prescriber, so your dentist. So POMs such as antibiotics are what would normally be given in dentistry. Aside from that, we've also got controlled drugs. So midazolam, diazepam, There's stricter rules with these, and this is just because they are addictive and harmful. So POMs and CDs tend to have a little bit more regulation around them in terms of how you can get hold of them. How do you know what a medicine is classed as? So there'll either be a P or a POM printed in a square box on the packaging. So if you've got any medicines floating around, it's worth just having a quick look on the packaging just to familiarise yourself with what that looks like. Control drugs will also have an inverted triangle and CD inside that triangle printed on them. Usually the POMs, but occasionally you'll find a control drug as a pharmacy medicine. There's lots of medicines in the industry, and you'll probably look around your practices and go, yeah, there's quite a lot around that you didn't even think of. So your local anaesthetics, your emergency drugs, antimicrobials, your fluorides, any anxiety medications or your sedatives. So for practices that do sedation, there's a whole host of lists. So it is really good to identify what you've got around so you know what rules need to apply for them. Then we need to consider how to handle, store them, dispose of them, anything that's stocked at the practice, and make sure this is done in line with legislation and guidance. So this includes developing a robust system that everybody in the practice follows. It can be easier to sometimes limit the number of people who have got access to the medicine in practice, and this just helps reduce the risk of them being misplaced. So, for example, if you've got a really busy practice, everybody's got access to them. It's so easy for someone to just grab something, put it down because they got sidetracked or they've been asked to do something else. So that's where just restricting that use can just limit them going missing. Then we've got to think about how to actually supply them if we are going to supply them and give them to patients to take home. So it's understanding who in the team can do what type of medicine can be given, and in addition, getting POMs labelled appropriately and ensuring your patient information leaflets are supplied as well at the same time. Then we also need to know who is trained. So only those who are appropriately trained, indemnified and competent can administer, supply, prescribe medicines. We've also got record keeping. So it's essential so you know that what medicine has been stocked at the practice, what can be accounted for. The patient records also need to be accurate and reflective of what has been done. And then finally, we've got audits. So quality improvement purposes, you need to be able to identify what improvements can be made. This will increase your productivity and reduce costs. And this can also be looking at antimicrobial use, stock control, or you could even look at other clinical areas such as your fluoride use in high-risk patients. And then finally, what is the prescribing mechanisms? So how does the dentist prescribe a medicine for use? So either to the pharmacy for dispensing, or how are they instructing other dental professionals to supply or administer those medicines? So you've got your patient-specific directions, PSDs. That's normally the instructions that are written in the note where it's specific to that patient. We've also got PGDs, patient group directions, which are applicable to hygienists and therapists. They are starting to be phased out. We'll touch on that more a bit further on. And then we've also got exemptions, which is the new change. So as you can see, there's an awful lot to consider with medicines. So whilst it can feel complicated, we're aiming with this webinar to just cover the main queries that we get surrounding biomedicines. So first of all, the law then. So there's a lot of legislation out there about medicines. So the key one for everyone to be aware of is the Human Medicines Regulations 2012. So this is the primary legislation which governs the safe use and management of medicines, and it applies to everybody in the UK. The Medicines Act is also linked to the Human Medicines Regulations. Then we've got the Misuse of Drugs Act and Regulations, which govern the use of controlled drugs. But we're not going to go into much detail on controlled drugs in this because that could take another hour at least, because controlled drugs are even more complicated. And then finally, we've got NHS healthcare service contracts. So they set the rules for primary care dentistry, and this includes the use of medicines in NHS dentistry. So it states medicines cannot be supplied to patients unless they are being used for immediate use. So a course of antibiotics would need a written prescription, but you could give them a medicine that is needed to get the effects immediately from that patient. So it's normally if there's a serious emergency reason. So in terms of exemptions, So it might not be applicable to everyone here because some practices don't have hygienists and therapists, but it is important to still understand these changes as it is a huge milestone in dentistry. So in June 2024, Schedule 17 of the Human Medicines Regulations was amended, which now means that hygienists and therapists can administer and supply certain medicines without a prescribing mechanism, such as your PGD or your PSD. The medicines that are listed in the legislation include medicines that the hygienists and therapists are more likely to need to administer or supply, such as your local anaesthetics and fluorides. We've included the full list in the updated medicines management overview, which is available in iComply. So if you're not sure of that list, you'll be able to find it in there. There's also a lot of confusion across the industry with exemptions and terminology. So exemptions do not make a hygienist or therapist a prescriber. This means that they cannot write out a prescription or prescribe medicines, such as your amoxicillins for toothache. A hygienist cannot delegate the supply or administration of medicine to other members of the dental team as well. So they cannot turn around to a dental nurse and say, can you apply this fluoride varnish to a patient? The hygienist and therapist would have to apply the fluoride varnish. The purpose of this change is to improve patient access to dental care. So it means that hygienists and therapists can provide complete direct access, reduces delays in care from having to request a prescription as well from the dentist. So it's particularly beneficial for NHS care as well, because hygienists and therapists can now open and close courses of treatment. And historically, getting a PGD on the NHS was really tricky. In addition to all of that, the guidance strongly advises hygienists and therapists undertake additional training to ensure that they fully understand this legislation and they are competent to administer or supply these medicines listed. The GDC also mirrors this statement, and it includes they must be competent and indemnified to work under exemption. All team members are also welcome to do this training so that they can understand the change as well. The preferred course is available through NHS England Learning Hub, and for Wales it's the HEIW Learning Platform. We've got these links in the overview as well, but they're free of charge, and as I say, anyone's welcome to attend the training. It normally takes around a couple of hours. It's important to work as a team, so it's important that the whole team understand what exemptions are if they're going to be used, so that they're used appropriately. And the preferred training also recommends that the whole team develop a standard operating procedure for working under exemption. So we've included this in our updated medicines management policy to help practices so they can use it. Practices who have PGDs in place can continue to use them for now, but you need to have a plan in place for when they expire. And this is to either transition to a PSD, your patient-specific direction, or to move on to exemptions. And that's because a PGD can be only used when there's no other mechanism available. But now exemptions are in place, we can use them. It's also important to note that still some factors to be ironed out with exemptions. So like with POMs that need to be supplied to a patient, the legislation states that they must be labelled appropriately. However, this is part of the dispensing process, which is preparing a medicine for supply. And currently, dentists are the only dental professionals who can be responsible for dispensing and therefore labelling medicines. This means that other members of the dental team cannot decide or dictate the specific details on the label, and the dentist is responsible to ensure that the medicines supplied are correct and appropriate for the patient and are also labelled in line with legislation. So how this works with hygienists and therapists with exemptions? Well, the NHS exemptions guidance provides more information on how supplying medicines under exemption currently works, but it also explains that medicines for supply need to be over-labelled. So this is a medicine which has been manufactured with a pre-printed label, and this includes the required instructions, and then there's space for the clinician to write the details such as the patient's name and the date on them. However, over-labelled medicines are not as easy to get hold of. Therefore, at the moment, the training and the advice is to make it easier for hygienists and therapists to continue to ask dentists for prescriptions for supply medicines, but continue to just administer medicines under exemption. It's anticipated that there'll be further changes in guidance and legislation to remove this barrier And as always, we will keep members updated and informed of any changes as soon as we hear and see anything. So we'll move on to discuss the stages of medicines management in practice. So we've first of all got administering. So this is the act of actually giving the dose of medicine to a patient to benefit from it immediately. So for example, giving a patient local anaesthetic so that you can carry out a filling. So GSL and P medicines can be administered by anybody who is trained and competent to follow these processes. So that's anybody in the team. However, it's a good idea for practices to have a local procedure in place. And this is to make sure that the medicine is appropriate for the patient and that there's no contraindications, such as if there's any allergies, pregnancy, or diseases which could be affected by the medicine. Due to higher restrictions with POMs, they can only be administered by qualified members of the dental team if trained, competent, and indemnified to do so. And this is following an appropriate mechanism such as your prescription, PGD, or working under exemption. Dental nurses, for example, can administer topical fluoride under a PSD, a written prescription, if they've carried out further training. But then for medicines to be administered to patients, they also have a right to request the patient information leaflet included in the packaging. So, for example, you could gain your consent for administering local anaesthetic to a patient, and they are well within their rights to ask to read the patient information leaflet before it's administered or even after. Patients don't often do this, but it's just being aware they can ask to. So then we've got prescribing. So as briefly mentioned earlier, so for the NHS patients, you need a written prescription, and this needs to be written on the specific FP10 or WP10 forms. And these need to be stored securely and closely monitored, so all forms can be accounted for. Practices should have a system in place to be able to track all forms so that you can act immediately if any are identified as missing. And healthcare inspectors will often check that you've got a prescription pad log in place and that prescription pads are stored securely. They will also check that forms are not being pre-written or pre-stamped. And then in addition, inspectors may also check that medicines are being prescribed appropriately. So, for example, the reason for prescribing antibiotics conforms with the current guidelines for prescribing. For NHS patients, pharmacy medicines listed in the dental practitioner's formulary can be included on a prescription. However, dentists can also direct patients to purchase these from a pharmacy if it is more cost-effective for the patient. Prescriptions for private patients must not be written on the NHS prescription forms, and instead, letterhead paper is considered appropriate, and it's a good idea to also scan it onto the patient record so that you've got a paper trail. Prescribing can also be carried out when deemed clinically necessary only. Sorry, get my words out. Prescribing should only be carried out when deemed clinically necessary. So, for example, you shouldn't prescribe a prescription-only medicine if a patient is demanding it and there's no clinical justification why they should need it. And that's really important because sometimes we can, as clinicians, be pressured by patients. So in terms of supplying a medicine, take home for use. So NHS patients can only be supplied the medicine if it's listed in the DPF by a dentist and if it's going to be for immediate use only. All other instances, medicines need to be prescribed. Private patients can be supplied with any medicine listed in the BNF. And GSL medicines can be supplied by any member of the dental team, but guidance recommends that practices do have a process in place for all team members to follow. So these medicines must be supplied in their original sealed packaging, and some GSLs, such as those containing paracetamol, have restrictions on how many can actually be sold to the patient. And this is applicable to retail. So you may have found that when you're purchasing paracetamol from a supermarket, you're limited to the number of boxes that you can purchase. There's also higher restrictions to P medicines and POMs, which can be sold or supplied by dentists or hygienists or therapists under the specific mechanisms mentioned. So no other team member can make the decision to supply these medicines to patients, and that's really important. Practices that do supply medicines should try to provide your POMs in exact quantities needed to address the problem in line with guidance. So, for example, If the patient is being prescribed 500 milligrams of your amoxicillin 3 times a day for 5 days, that means that only 15 tablets are necessary. So there's no reason to give them more than that. When we're supplying antibiotics in the correct quantities, it just reduces the risk of them being used for unintended purposes or giving them to family members. Sorry about that. The dentist can split packs, and if they're not available in the required quantities, but it requires a high level of practice organisation to reduce waste and limit the risk of human error in counting the correct number of tablets. Practices who choose to supply medicines to patients may have an effective system in place to ensure that medicines are supplied in line with legislation. But the key take-home message is to make sure that only team members who are qualified to supply medicines do so, and that there's a process in place to handle scenarios such as a patient coming to reception and asking for a tube of high fluoride toothpaste, as the dentist would still need to approve and label this before it is supplied to the patient. In terms of labelling, there is actually a legal requirement for what needs to be on that label. Listed what must be included on that label in the medicines management overview. And specific details include the patient's name, the practice address, the date of the medicine that's been supplied. And then in addition, if it's not already on the box, you need the medicine's name, directions for use, any precautions, and then to keep out of reach of children. As mentioned earlier, labelling medicines is the barrier for hygienists and therapists at the moment under exemption, so only over-labelled medicines can be given in this instance. And these medicines are pre-printed as well. So in terms of storage, so this is something that gets looked at quite a lot by healthcare inspectors. So medicines need to be stored securely and away from patient access. Consider restricting who in the team can access those medicines as well, and ensure that you've got an effective stock rotation system in place. So keeping your old stock to the front, and this will help reduce your costs from having to dispose of expired medicines. Then you've got your controlled drugs. So these must be kept in a locked receptacle that can only be accessed by authorised team members. Your buccal midazolam is your exception, because this can be stored with your medical emergency equipment as long as it's in an accessible location that cannot be tampered with by the public. Local anaesthetics can be kept in your surgeries in drawers and cupboards as long as it's away from patient access. You also need to ensure that they remain in the blister packs until use so that they remain sterile, and healthcare regulators will check that these are being stored in their blister packs as well. Medicines need to be stored in the recommended temperature range as stated on the packaging. So this means that some need to be refrigerated in a designated medicines refrigerator. So make sure that you're not storing your food in that medicines refrigerator as well, because that comes up quite a lot, and healthcare inspectors will also check that. If you're using a refrigerator for medicine storage, you need to make sure that you're monitoring that temperature as well, and you've got evidence of that. So we've got a checklist available, for example, in iComply. The temperature range needs to be between 2 and 8 degrees. If the temperature is recorded outside of these parameters, you need to create an event record and document any actions that have been taken. So, for example, contacting the manufacturer to confirm if the contents can still be used. In addition, we've then got glucagon, so out of your medical emergency kit, which has a shorter expiration date if it's stored at room temperature, as opposed to if you store it in the refrigerator. So if it's stored at room temperature, the healthcare inspectors will check that you've changed the expiry date and reduced it by 6 months, and they'll check that against the purchase invoice as well. The storage details should also be included in the patient information leaflet if you are ever unsure of what you need to do. For prescription-only medicines, practices also need to have a drugs book in place to meet your legal requirements so that you can accurately log each item that you've ordered from the point of order to the point of use or disposal, and this creates your paper trail. You also need to be able to identify the date it was obtained, the patient identification number or how it was disposed, the quantity that you've ordered, and batch numbers. By keeping organised with your record keeping, it can make it easier to identify where medicines are close to expiry, to ensure that you use these first, and that will reduce costs of disposal and costs of having to reorder the medicine. And these records can also help practices with carrying out their stock take and reduce over-ordering as well. So if you're finding that you're getting through a lot and you're having to bin a lot, you're obviously over-ordering. Healthcare regulators may check that the practice has a system to account for all this stock as well. So that's where we have the drugs book in iComply that can help. The details of the medicines need to also be reflected in the patient record as well, to accurately reflect what treatment has been provided. And then the clinician needs to document the justification of why you've used that medicine. So disposal. So when it comes to disposing medicines, the practice is responsible to ensure that medicines are disposed of correctly and appropriately in the pharmaceutical waste stream. Medicines will need disposing for the range of reasons, such as reaching your expiry date. A patient may return some unused supplied medicines. So it's important to ensure that these are disposed of in line with HTML 701. So practices need to consider what disposal arrangements are in place. So there's two usual routes, which normally are either through an agreement with a local pharmacy, who will dispose of the medicines for you. However, they are not obliged to dispose of these medicines. The alternative is through your pharmaceutical waste stream at the practice with your local waste carrier, excuse me, which is your blue lidded container. So for medicines being disposed of at the practice, Schedule 2, 3 and 4 control drugs, such as your midazolam, need to be denatured before you dispose of it in your pharmaceutical waste bin. So you can normally get your denaturing kits directly from your waste management company, or alternatively, you can inject your control drug onto an absorbent material like your cotton wool rolls and then place them in your pharmaceutical waste bin. Any practice, however, that is denaturing a controlled drug needs to have a T28 waste exemption certificate. They're free of charge and they last about 3 years before you need to renew them. The blue lidded containers are available for disposal of non-cytotoxic medicines. Now, these are usually suitable for general dental practices for all the medicines that we would stock. Cytotoxic medicines are those that are harmful to our cells, such as your cancer medicines, so not likely to be stocked at a general dental practice, and they would need to be disposed of in a purple lidded container. But I wouldn't worry about those. It'll be the blue lidded container for majority, if not all, dental practices. But if you are unsure of what you need to do, I would recommend contacting your waste carrier and they'll be able to advise you. Any medicines that are incorporated with sharps, such as your local anaesthetics, would need to be disposed of in your yellow lidded sharps bin. And then as part of your record keeping, you need to be able to account for all the medicines that you've been disposing of. So your drugs book should be completed to indicate that the medicine's being disposed of. And then you'll get your waste transfer note from the waste contractor as your evidence. If a practice has a local agreement with a pharmacy for disposal, it's essential to obtain a receipt as that evidence of disposal. And healthcare inspectors will check this evidence that they can see that it has been disposed of correctly. They may also ask team members to describe the process of how medicines are managed at the practice, including this disposal process. And then in terms of audit, so whilst optional, antimicrobial audits are frequently looked at by healthcare inspectors. So as part of the quality assurance governance frameworks, it's important and in the practice's best interest to carry out this audit. CQC like to see the CG Dent antimicrobial prescribing audit, and HIW like to see the CAPRO antimicrobial audit tool. You can also perform other audits as part of your quality assurance. So looking at prescription drug stock to check the quantities purchased align with the amount supplied and used. This will help you identify if your processes are working and all medicines are accounted for. Other audits could also look at fluoride use, so in prevention. And this could be used to help promote a preventative approach in dentistry. Healthcare inspectors will check that you're carrying out audits and action plans to identify ways that you can continually improve. So really important to consider. And then finally, what do you do if a patient has an adverse reaction? Well, an adverse reaction is an unwanted or harmful effect from taking a medicine. So you may have something like anaphylaxis. So what do you do? If it's serious, you need to report it to the MHRA yellow card reporting site. If it's a black triangle medicine, so these will have a little black triangle on the packaging in the patient information leaflet. These are just newer medicines on the market. Any reaction needs to be reported. So what is a serious reaction? It's basically anything that's quite severe. So it can result in a patient's death. It can threaten their life, cause them to be hospitalized, can cause persistent or significant disability or incapacity, could result in congenital abnormality. So we're talking really serious. And then if you've got a reaction, any reaction from someone taking a controlled drug needs to be reported to the controlled drugs reporting tool. In addition, if you do have these incidents reported, it's important to do an internal investigation as well. So you're following your accident, incident and reporting system in place. So you want to try and identify if there's anything that's been done at the practice which could have impacted the medicine. So storing it incorrectly. So is it need to be stored in the fridge when it's not? Has it reached its expiry date? Was it the right medicine for the patient? Was it an error? Should the patient have been given something else instead? Or was it another contributing factor, such as contains a colouring agent and the patient is sensitive to those? It may be that you cannot find a cause, and it could just be that the patient has reacted to that medicine, but it's really important to identify it if there is another cause as well, or a contributing factor. Healthcare regulators. So where do they? Healthcare inspectors will look at how medicines are managed as part of their assessment to seek assurances that medicines are handled appropriately. CQC will look at how practices manage medicines under the safe and well-led key questions, whereas HIW will assess this under the safe quality enabler. So from carrying out our research in healthcare inspections, there's some key differences and similarities between CQC and HIW inspections. So this Venn diagram is going to summarise some of the key areas in medicines management that we find are looked at by CQC and HIW. So both regulators will often check that medicines are stocked at the practice are stored securely. There's a system in place to monitor stock so that all medicines can be accounted for to ensure that none are missing. They will also check that NHS prescription pads are stored securely and only authorised team members can access them, and that there's a log in place which can account for all forms that easily and quickly identify if a form has gone missing. They will also check that the medicine's refrigerator temperature is monitored daily, and that if it does fall out of these temperature ranges, they like to see evidence of actions that have been taken. So this could be confirming with the manufacturer that the medicine's okay for use. If it's a recurrent problem, they'd also expect to see what the practice has done to mitigate this, so repairing or replacing the refrigerator. They will also check that things such as food are not being stored in the medicine's refrigerator as well. However, there are some differences. So CQC will look at practice systems for how medicines are handled, stored and supplied and disposed of, as opposed to HIW, who will look for the specific policy as required in the private dentistry regulations. And they will check that medicines are managed in line with this policy. Antimicrobial prescribing audit. So we've got the CG Dent guidelines audit, as we've mentioned, for CQC England, but for our Welsh practices, HIW look for the CAPRO antimicrobial prescribing audit. In addition, we've noted CQC inspectors do check that LA cartridges are stored correctly and remain in their blister packs until use. Some practices do take them out of the packaging when stocking the surgery, and again, to try and make it easier and quicker. However, the sterile environment is then lost if the packaging is removed. We've also seen inspectors confirm the process for supplying medicines to patients and check that medicines have been labelled correctly in line with the requirements of the human medicines regulations. On the other hand, for Wales, inspectors often check practices that are disposing through a pharmacy, obtain a receipt as evidence, and they'll also seek assurances that the practice does know how to report adverse reactions as well to the MHRA yellow card reporting site, and that they document anything internally as well. So, whilst medicines is a vast and complex subject, by laying down the foundations for record keeping, how medicines will be handled and prescribed, whilst ensuring the whole team understands their responsibilities, the use of medicines does become a bit more manageable. Don't forget our helpline are available to help support members as well with any queries. Our recent update on the medicines document set incorporates the changes in legislation, and it helps our members meet the requirements of healthcare regulators. iComply members, you can already access this update. It's all updated in the medicines management activity. If you're not an iComply member and want more information, please click on the link in the comments for more information. Super. Well, thank you for your time again, and thank you for listening. And as I say, you know where we are if you've got any questions. So thank you. Take care for now.